Corneal opacification is a major cause of blindness in the developing and the developed countries. It is associated with age-related cataracts and contributes to poor visual acuity. Suboptimal visualization of the lenticular morphology can render intraoperative difficulty. The decision for surgery will include either by planning phacoemulsification alone, or in combination with a corneal transplant. The various decision-making factors include evaluation of grade and extent of corneal opacity or haze, expertise of surgeon SICS, ACCA, phaco and transplant, donor availability, visual requirement of the patient, risk versus benefit, patient's choice. What all things we need to assess for planning combined surgery. The choice of surgery will depend upon the location of opacity. The surgical technique and site of incision will vary with the location of the corneal opacity. An inferior opacity can be managed by a temporal sitting approach, while in case a central opacity is peripheral, we can take a superior approach for incisions making. The IOL power calculation can be managed by optical biometry is mostly impossible. Axial length can be measured with ultrasonic methods. Other eye keratometry can be used for IOL power approximation. IOL type preferred would be monofocal. The various intraoperative maneuvers for best possible outcomes. Microscope with good retroillumination. Treatment glue to stain anterior capsule. Dispersive viscoelastic agents. Nylon hooks if pupil is non-dilating. Endoilluminator chandeliers. In this video, we show the use of retroillumination and how it enables us in performing a good capsular hexis. After hydrodissection, the retroillumination view does become hindered, so the trick here is to do a phaco salute by prolapsing the nucleus in the anterior chamber, thus enabling easier emulsification and prevents posterior capsular rent. In the case, we have a superior corneal opacity, and by choosing a temporal site for incision and as we shift to retroillumination, the view becomes much clearer and enables trouble-free phacoemulsification. This is a case of healed viral keratitis, wherein the patient refused for a combined surgery. Here, we make use of a 23-gauge assisted chandelier light retroillumination by fixing it inferiorly 3.5 mm from limbus. We can see a great 3D-like view which enables us to perform capsular hexis and gives us a perfect delineation of hydrodissection. Phacoemulsification in such cases initially is a little cumbersome, but provided with such a view is definitely worth the effort. In conclusion, case selection is extremely important, with a well-explained visual prognosis to the patient. A good microscope with retroillumination eases out intraoperative surgical manipulation. In the end, the surgical technique should be the one that's most comfortable to the surgeon.